Tonight I'm going to speak to you about some common topics in urology. I'd like to start with a quote that one of my mentors in urology was fond of discussing with me, usually over a glass of wine. This is a quote from Isaac Dennison, which is the pen name for Karen Blixen, whose life was portrayed in the 1985 Best Picture, Out of Africa. What is man when you come to think upon him, but a minutely set, ingenious machine for turning, with infinite artfulness, the red wine of Shiraz into urine? If that's true, that would elevate the specialty of urology to one of the highest medical specialties, because we deal with what goes wrong in that process of urine production. Two of those potential problems in the with urine production include the development of kidney stones, as well as the very common problem of urinary incontinence. And I'd like to give a brief overview, a historical perspective of each problem, and also talk about the current diagnostic as well as treatment approaches to dealing with each problem. This slide shows that kidney stones, urinary stones, is a condition that has afflicted mankind since ancient times, really since the dawn of civilization. I find it astonishing that archaeologists believe they've discovered a kidney stone that's 7,000 years old in an Egyptian mummy. The earliest medical writings that document treatment of kidney stones date from 1500 BC. These were also from Egyptian medical writings. And in 800 BC, the Indian surgeon Sushruta compiled the Sushruta Samhita. These were the first descriptions of surgical procedures to treat kidney stones. They also contained detailed anatomical descriptions of the urinary tract. Hippocrates, who is the father of Greek medicine, famously referred to kidney stone treatments in his Hippocratic Oath. The line is generally translated as follows: "I will not use the knife, not even on sufferers from stone, but will withdraw in favor of such men as are engaged in this work." I never really understood why that line was in the Hippocratic Oath, which we still take, but I can presume that maybe urologists had strong lobbying efforts even back in the ancient Greek times. Fast forwarding a little bit to the Middle Ages, this painting was done in the 1650s. It depicts a blacksmith who was suffering from recurrent bladder stones. Bladder stones are a little different than kidney stones in that they tend to form in patients with enlarged prostates who have trouble urinating. The story behind this picture is that this blacksmith had undergone a procedure by the lithotomists of the day, who were tradesmen who traveled from town to town to cut out kidney stones. He became so dissatisfied with the pain and troubles he had after two of the procedures that he vowed never to subject himself to the knife of the stone cutter again. And with his brother's assistance with retracting the scrotum, he used a kitchen knife to make an incision behind the scrotum and to remove the bladder stone that's shown in this picture. Needless to say, we've come a long way in 400 years, and we certainly don't recommend that you resort to do-it-yourself surgery, no matter how painful the stones can be. To give you some modern statistics pertaining to urinary tract stones, this is a relatively common problem. 3% of the people in this country would have kidney stones if we did imaging studies to look at their kidneys at any one time. Most stones pass on their own, but the lifetime incidence of suffering from a kidney stone attack is 12%. This figure is increasing, and there's various theories why that may be so. It is more common in men than in women at a ratio of 1.3 to 1, and this gender gap is also closing over time. The most common kidney stone compositions are, in order of decreasing frequency, calcium oxalate, uric acid, struvite, calcium phosphate, and cysteine. Kidney stones do pose a significant economic burden both to the individual patients who suffer from stones, as the average cost per stone episode is $3,494 as of the year 2000, and the total healthcare costs associated with treating stones are $4.5 billion per year. Those are direct costs. Kidney stones generally affect the working age population, and if you take into consideration costs associated with decreased productivity and loss of work, that number rises to $5.3 billion per year as of the year 2000. Some of the risk factors that are associated with forming kidney stones include a family history of stones, warm climates, and that's true. There's felt to be a stone belt across the southeastern and south central United States where they have warmer climates. Also, in climates such as ours, there's a higher rate of kidney stones in the warm summer months as opposed to the winter months. On a larger scale, in more desert climates, such as in Egypt, the lifetime incidence of kidney stones is up to 20%. Other factors associated with forming stones include the general medical conditions of obesity, hypertension, diabetes, certain types of urinary tract infections with urease-producing organisms, and certain medications can be associated with kidney stone formation. Dietary risk factors, data which was compiled from a nurses' health longitudinal study, which followed large numbers of nurses with frequent dietary surveys every 6 months, found the following 4 risk factors to be associated with increased stone. The surprise was the first one. The low calcium intake actually was found to decrease, or low calcium intake was found to increase your risk of forming a stone. So as recently as 10 to 15 years ago, we used to advise all stone patients to cut back on their calcium, and that's no longer the case. Low fluid intake, sugar-sweetened beverages, and consumption of large amounts of animal protein is also associated with a higher risk of forming stones. When you take a stone former and you evaluate them metabolically, the most common things that we find are that their urine volume is low because of dehydration. We also find high levels of calcium in the urine, and we find low levels of citrate, which is one of the natural inhibitors of stone formation in the urine. This slide just shows some of the basic gross and microscopic anatomy of the kidneys. The kidneys receive 25% of the cardiac output, or the blood that's pumped by the heart, is filtered in the kidneys. And the job of the kidneys is to regulate fluid balance and electrolyte balance, and to detoxify or to cleanse the blood. It's very important that the kidneys be able to produce a concentrated urine so that we don't have to always be taking in or consuming more fluids. But one of the problems with increased concentrations of urine is that the solutes that promote stone formation also reach higher levels. This is an interesting picture that I wanted to show you. I think it helps to explain why certain people form stones. One of the interesting things about stone formers is the overwhelming majority of stone formers form them just on one side when they initially present. And all of the factors that I mentioned, dietary factors, genetic factors, those are really all the same for your right or left kidney. So there's kind of a question of why would you tend to form stones just on one side and not form them bilaterally. And the theory that's been developed to explain that is shown on this slide. This is showing little calcifications. These are known as Randall's plaques. And they're present to a much higher degree in kidneys that tend to form stones. The theory is that these plaques tend to form as the initial substrate or the scaffold that the crystallization process of stone formation starts on. And you can see they're present in stone formers as compared to normal controls to a much higher degree. Still doing debate as to what actually causes those Randall's plaques to form. There are some theories that it may have to do with inflammation. But it also explains why just pure chemistry or saturation levels of the stone-forming substances in the urine is not enough to explain completely why stones form. So as we said, stones are a major health problem. I just wanted to go over some of the basics of how kidney stones form, how kidney stones cause pain. The kidneys are pretty much always working. They're producing urine at a relatively constant rate, regardless of whether or not a stone is present in the urinary tract. There's a common perception that stones cause pain because they may be sharp, and it's true that some stones do appear to have barbs on them, but that's not felt to be why they cause pain. When the urine cannot drain from the kidney down into the bladder, it causes the renal pelvis and the kidney capsule to swell, and that's an extremely painful event. When that happens, the renal pelvic pressure increases, and hopefully it would help the stone pass out down into the bladder. If the stone doesn't pass, then over a matter of a few hours, the body compensates by decreasing blood flow to that kidney. It's felt that if that obstruction is left untreated for about 2 weeks, there is a risk of permanent renal damage from obstruction of the kidney. The clinical presentation of stones is very dramatic. Most women or a lot of women who have passed stones will tell me that the pain is more severe than childbirth. A lot of stone sufferers fear that they're experiencing a life-threatening event, and they're brought to the ambulance by hospital. The pain is unilateral. It tends to start in the flank, and as the stone progresses down closer to the bladder, you can develop a lot of irritative urinary symptoms that may mimic a urinary tract infection, such as frequent urination or strong urges to urinate. Over 90% of patients with stones will have blood in the urine, either microscopic or gross blood, and over 55% of them have a family history of having kidney stones. In terms of making the diagnosis of the kidney stone, we rely pretty heavily on a non-contrast helical protocol CAT scan. This is over 98% accurate when it comes to the diagnosis of kidney stones, and it's routinely available in almost all emergency rooms. There are some concerns that we may be overusing CAT scan. When you look at the aggregate number of CAT scans that kidney stone formers have, it can be quite high. So there was a recent study that came out that proposed, instead of using CAT scan, maybe we could use ultrasound as the initial diagnostic evaluation for kidney stones, because that doesn't have any harmful ionizing radiation. That's an interesting thought, but nonetheless, CAT scan remains the diagnostic modality of choice today. Okay, so this is a slide that just outlines the management of dealing with kidney stones or renal obstruction. As stated earlier, we tend to start with a CAT scan, and we need to rule out some emergency conditions. The primary emergencies associated with kidney stones include sepsis. So If the urine is blocked, that's just a very painful event, but if the urine that's blocked is full of bacteria, there is a good chance that the bacteria, if they can't drain into the bladder, will get into the bloodstream, can lead to a very severe picture of sepsis. So we deal urgently with patients that come in with high fevers or high white blood cell counts. Also, patients in renal failure are treated more promptly and more aggressively than patients with normally functioning kidneys. Beyond that, the decision of whether or not to intervene for a stone versus to try to let it pass conservatively has to do with patient preference and has to do with the likelihood that the stone is going to pass. There is a strong correlation between stone size and likelihood of passage. Rule of thumb is 5 millimeter stones have roughly a 50% chance of passing. Smaller stones have a much higher chance of passing. And when we're dealing with the larger 8 millimeter stones, then generally intervention is required in order to relieve the symptoms. Other things that can be considered include medical expulsive therapy. That's usually with alpha blockers or calcium channel blockers, which can relax the muscles in the ureter. Those have been shown to increase your chances of passing a stone. And certain types of stones, particularly uric acid stones, can be dissolved by altering the pH of the urine because their solubility in urine is heavily dependent on pH. To get to some of the modern techniques of removing stones, in 1976, a procedure was developed called percutaneous nephrolithotomy. Prior to 1976, all kidney stones that didn't pass spontaneously were pretty much treated with open surgery. And unlike some other surgical conditions, such as cholecystitis or appendicitis, where the treatment involves removal of the offending organ, obviously when we're treating kidney stones, we don't want to remove the kidney, we just remove the stone. Patients who've had recurrent stones in the era of open surgery often had complications or difficult surgeries related to repeat procedures. Even today, kidney stones are a significant cause of end-stage renal disease, as approximately just under 1% of dialysis patients are on dialysis because of kidney stones. But these developments in modern stone surgery have gone a long way towards reducing this. Percutaneous nephrolithotomy is performed by placing a wire through the skin directly into the kidney and then placing an access sheath around that wire. Steel surgical instruments are then inserted through the sheath, and the stone can be broken up using ultrasonic energy sources or removed using graspers. Shortly after the introduction of percutaneous nephrolithotomy, in 1980, a procedure called extracorporeal shockwave lithotripsy was developed by the German aerospace company Dornier. Their first model lithotripters are depicted on the left side of the screen, and those were only located in large hospitals. They required the patients to be placed in a water basin, and then shockwaves were aimed on the stone to fragment the stone into small pieces. This was a completely non-invasive procedure. Nothing is put into or into the patient during this procedure. Major complication is just after the stone is broken up, the patient has to pass the stone fragments out naturally. The picture on the right shows that they've been able to make the equipment much smaller, so that today most lithotripters are portable and they can be put into a van and brought from hospital to hospital to treat patients with stones. In the 1980s, we saw the development of very small surgical telescopes called ureteroscopes. This relied heavily on development of fiber optic instrumentation, and this picture shows that modern flexible ureteroscopes are able to be advanced through the body's natural orifices up into the bladder, all the way up the ureter and into the kidney. And very small laser fibers can be passed through the scope to break stones into small pieces, or the stones can be basketed and extracted using ureteroscopy. Patients who have had kidney stones or that have had to go through a surgical procedure to remove a stone are very highly motivated to try to prevent that from happening again. And the way these patients are evaluated is first with a metabolic evaluation. Their stone is sent off to the lab to determine what it's made out of. And then we check 24-hour urine and serum chemistry studies to see if there are any metabolic abnormalities that can be addressed. The most common factors would be low urine volume, high urinary calcium levels, which can be addressed with a thiazide diuretic, which will lower the urine calcium, and low urinary citrate. Citrate can be supplemented naturally by drinking lemonade or lemon water, or it can be supplied as a medical pill. The standard dietary advice that we give to all stone formers is to increase their fluid intake and to restrict intake of animal protein, which contains oxalates and salts, which promotes an acidic environment. As I stated earlier, several studies were done looking at dietary calcium restriction, and that was not found to be beneficial and is no longer recommended. Calcium intake is also important for promotion of many other health conditions. I'm going to switch gears here a little bit and talk about another very common problem in urology. As I stated earlier, kidney stones have afflicted us since ancient times. But there's been a revolution over the last few decades in how we deal with and treat patients with urinary incontinence and overactive bladder. For many years, it was felt to be just part of natural aging and not something that really warranted medical attention. But that's really changed, and we've started to focus more on quality of life as opposed to just focusing on prolongation of life. And with that has come a lot of increased research and developments in management of overactive bladder symptoms, and I'd like to discuss some of those with you tonight. First of all, treatment of urinary incontinence depends on what the underlying etiology is, and in simple terms it can be classified as arising from dysfunction of the bladder or dysfunction of the urethra. So if the bladder can't store enough urine, the classic symptoms would be excessive frequency of urination as well as strong sudden urges to urinate that are difficult to defer. This is a description of urinary urgency and is often associated with urgency incontinence. On the other hand, if the bladder is unable to empty, either because the bladder muscle becomes weakened or because there is an obstruction to urine flow, then overflow incontinence will result as the bladder pressures rise. Urethral dysfunction is what's commonly known as stress incontinence. This is loss of urine that's associated with increased intra-abdominal pressures that are associated with coughing, sneezing, laughing, or physical activities like that. Stress incontinence can be classified as anatomic, which is a hypermobile urethra, which descends below the level of the pelvic floor with increased abdominal pressures, or it can be due to intrinsic sphincter deficiency, which is seen in certain neurologic conditions or in certain patients who have undergone radiation treatments for cancers. As I said earlier, it is a major shift in our thinking to characterize overactive bladder as a disease. But it has been demonstrated in multiple studies that overactive bladder does impact patient quality of life. It causes patients to alter their behavior or in social situations, or to avoid certain social situations altogether. And the primary reasons that patients seek treatment for overactive bladder are because of frustration from the symptoms, embarrassment, and physical discomfort. Patient education is still needed when it comes to discussing overactive bladder. About 3/4 of patients report that they waited longer than they should have to seek treatment. I think we have a way to go with providing follow-up for treatment, as only 20% of the surveyed patients report that they're extremely satisfied with their current treatments. And the reasons that patients don't seek treatment are 26% didn't know about available treatments, and embarrassment, for 23% embarrassment to discuss the issue is still an issue that we have to try to overcome. So when we're managing patients with overactive bladder, this slide shows the typical treatment pathway. The first thing patients will usually do when they lose urine is just use pads. Physical therapy and biofeedback can be helpful. For example, for patients with urgency incontinence, it's important for them to be educated that the reason they lose control of urine is because their bladder starts to contract before they are able to get to the bathroom. So if they go to the bathroom on a timed schedule before those urges come, a lot of them can control their symptoms through lifestyle modification. There are medications that can also decrease bladder contractility, and there's dietary modifications, including fluid restriction and avoiding caffeine or other bladder stimulants. If these conservative treatment options are not successful, there's a new treatment that I'd like to discuss with you tonight called InterStim. This has been out for about 10 years, and it involves electrically stimulating the pelvic nerves to decrease urinary urgency and frequency. The nice thing about this treatment option is before a patient would go through an InterStim implant, there's a test procedure that they could go through to try to predict if it would be successful. Again, we touched a little bit on medical therapy for incontinence and the conservative treatments. Again, they can include physical therapy, bladder training, dietary and lifestyle changes, and the following medications. This is not a complete list of the anticholinergics. There's at least a dozen anticholinergics that are available that help with the excessive frequency and urgency of urination. One of them, the oxybutynin patch, has recently been approved at a low dose as an over-the-counter medication. And approximately 2 years ago, there was introduction of a new class of medication, which is the beta-3 agonist Mirbitric, has been used to treat overactive bladder symptoms. In head-to-head studies, none of the agents has ever been shown to be superior to the other. And choice of medication really depends on individual patient response, as well as limiting the side effects. These drugs can cause significant side effects of dry mouth, constipation, etc. Important to realize that medications aren't the only treatment. I think sometimes patients feel like they're getting up the courage to bring up this problem with their physician. They're prescribed a medicine, and then if it doesn't work as well as they had hoped, there can be they can feel very disappointed. What we know from just looking at prescription refill patterns is that patients seem dissatisfied with some of the medications that are prescribed to them. Looking at the California Medicaid program, within 6 months, over 70% of the patients that were prescribed overactive bladder medicines discontinued them, and that went up to 80% over a year, after 1 year. Comparing this to other common health conditions, again, you see that only 28% of patients on the overactive bladder medications remain persistent at 6 months, And these rates of adherence to taking the medication were lower for overactive bladder patients than they were for any of the other common medical conditions shown here. So I think it's important to educate patients at the outset that if the medicines don't work, there's other treatment options as well. That generally includes a more in-depth evaluation with either cystoscopy or urodynamic studies to further define the problem, and therapy with either a biofeedback, which is aimed at suppressing the urges of urination, physical therapy, which can sometimes be useful for stress incontinence or using Kegel exercises, and sacral neuromodulation with interstim therapy for frequency and urgency patients. So what is sacral neuromodulation? It's a procedure that focuses mild electrical pulses on the nerves that control the pelvic floor and the lower urinary tract. It offers control of symptoms through direct modulation of nerve activity, and it really has a different mechanism of action than the medications, with focus primarily on the muscular component of bladder control. This targets the nerves. This shows us just a picture of the interstim device. This is the device that's implanted. It's about the size of a small book of matches. It's implanted in the lower back in patients, and there's remote control that can be used to adjust the settings or to change the programs that it would be set on. This isn't a treatment approach that's unique to overactive bladder patients. This slide shows multiple conditions for which neuromodulation or electrical stimulation has been found to be useful. I think what you'll see they have in common is they're all relatively common conditions with a neurologic etiology for which medical therapy is often unsuccessful. So Parkinson's disease, obsessive compulsive disorder, tremors have all been treated with neuromodulation. Chronic pain in patients whose pain is refractory to to standard approaches or to pain medications, gastroparesis, and bladder control and bowel control as well can be treated with neuromodulation. One of the nice things about the interstim procedure compared to other surgeries where you go through the surgical procedure and it either works or it doesn't, with interstim there is a trial assessment process that patients go through because it doesn't work for everybody. The interstim electrode would be inserted on a trial basis and connected to a test box stimulator that the patient would carry in their pocket. Patients are then instructed to keep a log and determine if they find the procedure successful. The trial procedure can be done either as a basic evaluation, which can be done in the office with just local anesthesia, which is convenient. However, it's difficult to fix the wire in the office in exactly the right place, so sometimes there's an issue if the wire moves just a few millimeters. The stimulation may not be successful. A more advanced evaluation can be performed in the operating room where the lead can be fixed into place. Looking at efficacy of interstim, at 12 months' time, 79% of the urgent continence patients did achieve clinical success, and 45% of them report remaining completely dry, with an additional 34% reporting over 50% reduction in leakage. 64% of urgency and frequency patients achieved clinical success. And one of the interesting things about interstim, and one of the kind of constant questions people have about it, is How does it work for both frequency and urgency of urination, as well as patients with urinary retention or patients who can't empty their bladder? And we don't really have a great answer for that. I don't think on a cellular level we can explain why it would work for those two seemingly opposite conditions, but there is data to support that it does work for urinary retention patients as well. 61% of them could completely eliminate the use of having to use catheters to empty the bladder, and an additional 16% report over a 50% reduction in catheterized urine volume. Again, over 5 years, the results are durable. They do fall off, so it's not a perfect procedure, but we're still seeing 59% of urgent continent patients achieving over 50% reduction at 5 years after implant, and 71% of urgent continent patients who reported heavy leaks at baseline achieved over 50% reduction in leaks per day. Similarly, for the urgency and frequency patients, 56% achieved over a 50% increase in volume voided per day and an improved degree of urgency. Urinary retention, likewise, from 1 to 5 years, we do see a fall off in the success rates, but still 78% of urinary retention patients achieved over 50% reduction in volume per catheterization. So therefore, they'd have to catheterize less. Okay. Any procedure can have some adverse events. Some that are unique to InterStim would include pain at the implant site, technical or device problems. There can be, it is an electrical device, so there can be some mechanical failures associated with it. There can be undesirable stimulation or sensations or infection of the device. To summarize, I think overactive bladder it's a very common problem. It's a quality of life issue that a lot of people face, and in a lot of ways it's a hidden problem. So I think it's our job as healthcare providers to create the environment that patients are comfortable discussing these problems in an open manner, because they do occur frequently and they do affect people's qualities of life. And it's also important to emphasize that treatment doesn't end with just medications or with pads. If conservative treatments aren't successful, we do have new and promising alternative treatment options that are available. So I started with an Isaac Denison quote, and sometimes when I was in medical school, I felt overwhelmed by a lot of the studying and the books, and I took solace in this quote, which just I think simplifies things but has some truth in it. The cure for anything is salt water, sweat, tears, or the sea. So I thank you for your attention, and thank you for coming, and I'd like to open it up for any questions that you may have.